So let's talk about a real case scenario at Munson. So we're in northern Michigan, classified as a sole community rural healthcare system, and I'll talk about that in a little bit. But Mike is 61 years old, he's a kidney cancer patient. So he, of course, is going to be on a treatment regimen that consists of Opdivo and Yervoy, because I never can say those other words. He does have commercial Blue Cross Blue Shield, and so what that means is, most of you know, he has a high out-of-pocket cost. And the risk of that, though, is that how do we get that covered for him? Because he doesn't have the income that's going to be able to support that treatment regimen. And so what will happen to the institution is it either will go to uncollectible bad debt, and so that's where our financial navigators are so critical, because he's unable to afford his treatment. So he met with our Munson financial navigation team and they were able to get a manufactured copay card to cover that out of pocket. So basically that's helping both the institution and the patient's bad debt. So the patient did benefit from $5,980 from that. And the health system also benefited from that. So we know the hardships, Lori put that right on the table. We know our cancer patients experience rapid rising out-of-pocket costs. 73% of them, for example, have some sort of financial toxicity. And then we, as the healthcare system and the cancer institutes as well, incur bad debt. And so you can see from the slide there that the provider burden, about 66.7% of people pay their bills, but then we have the bad debt risk as well. And so that's the ones that pay their bills that have balances of greater than $200. So there's Cowell Family Cancer Center. We opened in 2016. We're the largest healthcare system in northern Michigan. We have 7 other smaller rural hospitals that we have infusion clinics at, and we have medical oncologists that go to those. So the cancer center is the hub in Traverse City, and then those were our spokes. So we diagnose within the region about 2,200 patients altogether. Our financial navigation program, though, was started when Clara came, and it was in 2013. And at that time, our physicians were in separate practices. They had their own infusion centers. The hospital had their own infusion center, and we were going to merge all of them together. So our cancer center has 44 chairs, so we merged all of that together. But still, we started with 1.6 FTEs, and to date, we still only have 2, which we know, as the polling question earlier, is really not enough. So what was the rising need for automated solutions for our program? Just a note on our regional centers. So we're 99 chairs altogether, but some of our centers have as little as 6 chairs, and then the next highest one would be 16 chairs. So those folks do scheduling, business management, prior authorization, and then try and do financial navigation at the same time. So at the Cancer Center, we're the hub with those 2 FTEs that really try and help our regional area too. So something needed to happen. It was so human being intensive that we needed to look for a solution. So we determined really how to prioritize our patients was really most important. So we needed automation to reduce the financial toxicity and really maximize the assistance to our patients. Our plan when we opened the Cancer Center was that the financial navigators would see every patient. And with the halo effect of opening the Cancer Center, it just became too overbearing for them. We also wanted to maximize our return on investment for the staff that we did have and increase our revenues. So we decided we needed to be proactive. So when you think about the bubble, this is our entire population in northern Michigan that we serve that has cancer. then the pink dots are all the individuals that have financial toxicities and at varying degrees. And the green dots are patients with actually good coverage. I have to make a note to what Lori said too. October can either be good or bad. October, if you're diagnosed with cancer, you end up paying your deductibles and co-insurance twice. But the other opportunity for October is that we can enroll patients in other insurances, so it's a double sword. So as you can tell, 2 FTEs are not enough to meet our needs, so we needed to find a solution. We wanted to be able to identify the patients with the highest need or risk, so really to prioritize the patients. And we wanted to find who those patients were before they started treatment. I don't know if in many of your programs, it's forever the primary nurse, you're getting the phone call, Mr. Jones needs to start treatment, can we get coverage for him? And the doctor wants him to start tomorrow. So we really want to identify them before they experience financial crisis. So dynamically, how do we analyze our entire patient population? They have changes to their insurance, they have changes to their treatment plan constantly, they have changes to financial status. So let's look at another patient. We have Mary, who's 76 years old. She's also a kidney patient. But what's unique about her, she is just original Medicare. So you know what that means. That's a risk of 20% out-of-pocket expense to her, which can be upwards of $25,000. So our financial navigators needed to assist with insurance optimization for her as well. And again, that's helpful in October when we can open enroll people in certain policies, but that's not always the case. And we know that Mary was unable to afford her treatment on a fixed income. So she started treatment in 2019. She met with our financial navigation team. And while the free drug is neutral to the bottom line for the cancer center, there's no drug cost or revenue, actually. However, she was able to benefit at $23,000. Again, the emphasis here is that we don't benefit from it as an institution. So that's our difficulty when I'm trying to request more staff for financial navigation. This really doesn't go to bad debt because the patient pays it, but I've got a team of people that are working to get these benefits for them. So there's a need to accurately measure all that our financial navigators do. What's the challenge? Most of our programs, and we started out with this, was using an Excel spreadsheet that unfortunately the financial navigators themselves had to fill out, so that was time away from direct patient care. And we had to report as a nonprofit cancer center what our community benefit was. And for me, always trying to secure more staff, or if I have a replacement, to prove that we still need those individuals. So we really needed some more accurate information to be able to meet these. So there's a tool that we adopted and that we're working with to really help us measure our key measures and results and to get organizational buy-in. Tracking my team's productivity and to analyze the trends. So how do we automate this? That's the key, instead of using an Excel spreadsheet. So we chose an automated software platform, and we evaluated many different tools that were out there. TaylorMed became the most comprehensive platform because it really offered options to take the financial navigation from the start all the way to the end. And it has some important features for us. It actually interfaces with our EMR. We use ARIA. It does predictive analysis and automatic benefit investigation. I think that's one of the key components, and an out-of-pocket projection. Our patients are getting more and more concerned of their financial toxicity and really want to know what this is going to cost. And then we wanted real-time analytics and reporting. So yep, Shirley, do you want to do the magic for me?
Sure.
Since I'm not that tech savvy, I just wanted to demonstrate how this tool actually works. There was a few things I wanted. I wanted to be able to automatically have a system that would scan our patient population that was coming up for treatment in the next week. And so then, how would we be able to connect that patient with the proper foundations? There's a human factor to all of our workers that they're going to take the path of least resistance and try and find treatment patients only that have manufactured copays. But there's other foundations out there that we really wanted to maximize, and I didn't feel we were doing that well enough.
Cool. Thanks, Gabby. So basically, we partnered with the Munson Healthcare System about 2 years ago, and I wanted to briefly show you how their system looks like, to kind of show you in action all of the things that were identified as a need and the way that we decided to design together a solution for them. So basically, this is their beautiful cancer center in Traverse City, Michigan. And one of the things I wanted to point out is, as Kathy mentioned, one of the key components that we identified after we applied automation is that even if we are able to bring in a system that helps with that, still the need is for the financial navigators to work on the patients at the right time. And how do you do that? About 3,000 patients newly diagnosed and in ongoing treatment are going through this cancer center each year. With only 2 financial navigators, it's really hard to identify who are those patients that will have the highest financial risk on the one hand, but actually have at the current time an opportunity to offset those costs with one of those copay foundations or copay cards. So this is the bottom here, which is called top opportunities. So instead of only going into the system, which they can, and search for those patients that are coming to them, they can go into the top opportunity list and detect those patients that the predictive analytics of the system are flagging for them, which is only the subset of patients from the entire patient population that have existing out-of-pocket balance and actionable opportunities that they can go in and enroll. And if we look at the patient, for example, this patient that Kathy mentioned before, first of all, they see the medical journey that we extract from the EMR, and this is something that is constantly updated. So any added cycle or reduction of dosage, or if there is a change to the insurance plan, is always reflected there dynamically. And as a result of the benefit investigation, we are able to say what will be the projected out-of-pocket expenses, which in this case was almost the full amount of the out-of-pocket limit. And then what the system allows them to do is automatically detect, in this case, the manufacturer programs that they can enroll on in order to offset those costs. And when they go into such a case, they are able to do that pretty automatically, because they don't need to kind of look and find a needle in a haystack of that specific patient that would represent a significant burden for the patient themselves, but also a risk from a billing perspective to the hospital. So that's kind of one example I wanted to show you on how it looks in action. And also wanted to go back to what Kathy mentioned about measurement. When we started working together with Clara and Kathy and the entire team, we noticed that when you are looking with the Excel spreadsheets on the results, it's really hard to associate each dollar saved to the bottom line influence or community benefits. And that created a challenge. How do you measure the impact of the financial navigation program? And this is the live analytics system that they have. Basically, it goes a level on top of the financial navigation database, and every patient that goes through the cancer center automatically goes into the analytics dashboard. And here you can see, for example, how many patients are currently in the system in this calendar year, how many got assistance, and then these 2 metrics here, the revenue increase and community benefits, are the most important ones. Basically, we have developed together an accounting system that associates each dollar saved to either revenue increase and/or community benefits. And think about the patient before, the first one. They have about $6,000 of savings. Should that be going into revenue increase or community benefits? In his case, it was both. But the second patient, Mary, she had a free drug program, which definitely contributes to her benefits, but nothing that influences their bottom line. And this is a way for them to be able to track that and also generate trends over time. They can set goals to the team to see how they are doing, and then also see the main drugs that get most of the assistance, the key manufacturers and foundations from which they get the assistance, and also to have a really close look at the distribution of their patients from a demographic point of view, only on those patients that actually receive and get the assistance. So based on age, you can see that there is a sort of a bias towards the elderly population with the Medicare beneficiaries, and then also a diagnosis and payer mix distribution, where in Manson's case, most of the patients are Medicare beneficiaries. Last thing that they can do is actually track the performance of the team itself. And this is something that both in Manson and in other places we see is very profound. To be able to track as a manager what your team is doing and set goals like for the next week, month, year, and so forth is very important to take your financial navigation program and increase it and improve it over time. So that's something that I have to thank Kathy for the support and Clara at the beginning for being able to get the feedback from the field and apply it to the tool, but I think that kind of wanted to show that in real life. Thanks.
The tech part, thanks. I think another important aspect was finding the foundations that maybe just have a small window of time to open, and that's where I found with just 2 FTEs at the Cancer Center that we were missing those opportunities. And so with the predictive analytics, they were like, wow, this, you know, whether it's Lymphoma Leukemia Society or this one just opened or the Kidney Foundation opened for this 30-day window, and we got support for our patients that we otherwise probably would have missed. We might have gotten, of course, the drug support, but we could have missed that other offset. The other thing that we didn't talk about was the free drug program. I don't know in your facilities, but it's been, the more it happens, it's so hard to track. And we had in our pharmacy just a wall with a whiteboard on it, and they were just trying to put all the patients' names on it and track when that patient was coming back and how they got that drug in. So I can't prove to the financial team when I'm asking for more resources that hits the bottom line, because that drug comes in and we don't pay for it and it goes out. But I've got people working on calling, making sure its pedigree is all right. We're giving that drug to the patient. And so all of that I needed to try and quantify. So I had asked for, I really need a dashboard. And so this dashboard comes monthly. And then eventually, we just closed our fiscal year out June 30th. So that was last year's data. And then we're gonna be able to do a side-by-side. So I'm hoping as we continue to grow our program, we're gonna be able to really bring more financial navigators into the fold. So to me, I needed an automation opportunity to be able to justify what it is that the crew is doing and to maximize our patients, because we cannot touch each and every one that walks into the Cancer Center. So that's our case study. So thank you.